Everybody, actually my job is much easier. My friends actually dwelled upon in details. Yes, we were speaking about treatment refractory Tourette syndrome. What should be important, what would be our treatment options, and I will be telling a refractory case presentation with a 1-year follow-up, the challenges encountered by the cases and how can we help them. I will try to summarize them. Before saying that a patient is treatment refractory, we should know very well about the history and the previous treatments. What are the combinations? How long the dose had been taken? Our doses were sufficient? Were there side effects? Also, is there a wrong diagnosis or untreated comorbidity? Or is there a lack of access to available therapies? Only after analyzing this we can decide a case about its, if it is really treatment refractory. But treatment refractory TS, who had defined it? They are mostly DBS works. They are a result of certain consensus. DBS database registry study group had defined this criteria. A correct DSM-5 diagnosis is needed. Tics should be the major source of all syndromes, and they should be strong, 35 severe, 35 over 50. It should be minimum 5 years and minimum 1 year of severe continuation of tics. If age is older than 18 and involvement of and of course there are refractory cases also in other ages, but we have a limit of older than 18. If it's lower than 18, then ethical committee should take it into account. We should see the video documentation of movements so that we can show that they are severe tics, and at least we need failure of 3 pharmacologic classes. We should know that they had been used in the sufficient doses. Our comorbidities are appropriate. Is there a stable medical condition, and psychosocial status, and is there suicidal or homicidal ideation? If we shouldn't have them, so that we can define them as severe, as referring to surgical intervention. Why we need treatment refractory? If the tic severity is greater, if fine motor deficits are early, and if there is a reduction in total coded volume, these patients can be much more resistant. The comorbidity is not that effective. The OCDs are not going worse. There is not any genetic markers found here. There are genetic works, but we don't have enough level of data. New pharmacotherapies especially should be changed if they are accessible before surgical intervention. With Safarbe we used some of them. I will dwell upon them very shortly. Anticonvulsants, especially about there are some studies related to topiramate, but there is a phase 3 study needed. There is not enough level of evidence. Clonazepam is fully effective, but it has a dependence effect. There are certain concerns about the adverse effects of tetrabenazine, so there are certain studies over it. They have not been studied on clinical trials journal, but they are apparently promising. In dopamine receptor blockers, ecopicam is a novel D1, D5 receptor antagonist. There is a multi-center work over this agent, and a decrease in scores had been shown, and there is now a study on children and adolescents. Cannabinoids are especially important for me because the marijuana, medical marijuana, this is especially asked by patients, is it really curative? In certain states of America, the medical use is free. We are working with the Tourette volunteers, and they are asking this especially. To what extent marijuana can be effective? Is it possible to use it? We want to use it. I want to also develop on this. Can we really make cannabis safer, and can we use it in treatment? Yes, actually. Cannabidiol form is especially has a different effect mechanism, and it's not hallucinogenic. It decreases anxiety. It doesn't create a psychosis. On the contrary, it has antipsychotic effects. It is reversing the psychotic effects, and really, it can be made safer. A study conducted in Yale, it's shown that it's not psychotic, rather an antipsychotic, and effect mechanism. It's similar in the cellular level with the other antipsychotics. Also, there are legal restrictions, neurocognitive side effects, and concerns regarding addiction and abuse, and FDA still didn't approve it. Because of this, can we make medicines in the same pathway but not having a addiction effect? Domes and Comes et al. Describe 3 agents, especially URB 597 is the most promising agent, which has an inhibitor of anamneritic hydrolysis to increase endogenous anamneritic, and there is a recent study over adults. About glutamatergic system, they are not still proved. Riluzole, Nacan, and Prozac is being used, but we don't have evidence. The bioacids, finasteride, it's used for alopecia in a patient, and it was shown that it decreased the tic severity. But there is a pilot study on it, but they found a partial effect in males, and the evidence was not enough. We used all medicines, we tried all combinations, but still our case is refractory resistant, especially if we are speaking about a child and adolescent case. What will we do? We have less invasive and applicable methods. There are 2 actually, except the deep brain stimulation. One is RTMS. It's not invasive, it's safe, it's good, it's tolerable, so it's preferable, and an average reduction of tic scores of 34% has been found, but it's more effective when there is a comorbidity. If there is a comorbidity, it's more preferable, and especially in OCD, it's more effective in comorbidity. We don't have enough data. We cannot directly suggest, but we can give information about its benefits, and we can try it. We tried it in our 2 cases. In the first one, there was improvement, especially after 15 days, the effects had come to 4. After second practice, after second application, we didn't find enough level of benefit, so we didn't repeat it. Mostly, it can go to 15 sessions or sham. DBS had been in 1977 had been used because thalamotomy decreased the tic findings. Van de Waal and colleagues made DBS instead of thalamotomy because thalamotomy was too invasive. They have 3 basic components. There is a generator, there are electrodes and cables. The brain pacemaker, electrical impulses, and cables. And with the skull, with the local or general anesthesia, it can be implemented. 15 or 20 days ago, our case went to DBS. I will be telling you his process. FDA hasn't approved for Tourette syndrome, but in Tourette syndrome, dyskinesia and Parkinson, it has been approved. There are various regions which had been selected, especially thalamus and globus pallidus internus, and the globus pallidus externus is especially selected, which is related to GPI. How is the process? We are issuing reports having the signature of neurologists, psychiatrists, and neurosurgeons. Also, we have to mostly increase the histamine diagnosis so that they can be approved and paid. You need a very detailed anamnesis. I will be showing you our tables. If it's really refractory and all 3 physicians accepted it, it can be approved. Also, below 18, it doesn't have any indication, but if you don't have any other choice, you can prefer, as the case was in our case. This is the criteria which is created by the foregoing team. Most of them had been covered, but one of the most state-of-art is in randomized double-blind crossover trial which had been issued in Lancet Neurology, which had found around 14 point of improvement. And also there are 3 more randomized works. They are clinically significant improvements in these cases. So we can call it evidence-based for adult patients, despite that it's still in experimental phase. We are not using this a lot. We sometimes use it for comorbidity. Now this is our case. We cannot hear her at the moment, so we cannot translate. A girl came in June 2016, 10 years of Tourette syndrome history. First word in 3 years old, blinking and nose sniffing, and then complex vocal tics, complex motor tics and vocal tics had been added after 6 years old. Especially in recent 2 years, it was the most severe era. She was really very in bad condition. She was having complex motor tics which are self-mutilating. She thought that everybody was looking at her. She was afraid that she would harm some other people because she had blinking, nose wrinkling and neck jerking. Even we felt very desperate when we saw her. This is a short video.
As you can see, it has an impact on her eating lunch, going to the school, socialization. Yes. Parents were separated, single child, lives with her mother. She was a second-year high school student without being able to go to the school. No other medical disease or surgery history, no known family history of psychiatric disorders, no known allergies or drug abuse or alcohol abuse history. Psychopharmacological treatment history. When the first text started, she received fluoxetine treatment. Then she went through this for a long period of time. She said that she was experiencing many anxieties and that this worked. And then risperidone was added, and saying that it was replaced by aripiprazole on the accounts that it made it worse. Haloperidol was then replaced after 2 years, and then it was added the other treatments. A short period of diazepam treatment. Clonidine has been added together with piperidone. It increased the prolactin levels, so she was unable to use it for a long period of time, 1.5 years. And then clonidine, aripiprazole double combination. And when we received the patient, she was using fluoxetine and aripiprazole for 1 year, and she said that it didn't work. We said that this was a Tourette syndrome patient. You need to send her to the neurological examination, especially in the high episodes. Normally we expect a decrease in the tics, especially during the adolescence, but there was on the contrary, there's an increase. EEG and MR were normal. We carried out the blood tests, and then we received the patient. We decided to increase aripiprazole up to 30 milligrams because it's an effective dose. From time to time, we use diazepam in order to take advantage of its sedative impact. For 2 months, we have used this without any benefits. And then we added the guanfacine. I'm sure that some of you has used this. It's possible to import this through the Chamber of Pharmacists. We started as 2 multiplied by half for 1 month, but we couldn't use the effective dose for aripiprazole. And then there was another combination which wasn't used before, haloperidol and piperidine and aripiprazole combination. It without any benefits. Pimozide, high sedative level, and we couldn't continue this because of the high sedative levels. And in 2016, when she is in 12th month, we have added the TMS next to the tetrabenazine. After the first TMS, there is this benefit rate, which is 4. She felt better for 15 to 20 days. There was a 60% decrease in the tics, but it took very short. And then, by the way, reverse therapy has been added together with some of our therapist colleagues, and there was no advance. When the tics are very frequent, it's not possible to use the therapy. It's not possible to talk about this cognitive process when there's frequent tics. Tetrabenazine and the second TMS, it was in vain again. She was harming herself. She was experiencing huge problems. None of them went back, none of them were reduced, and she was negatively being influenced. And we thought that this patient was appropriate for the DBS, and we sent the patient to the neurochirurgy. As a result of this, it has been 15-20 days since she underwent DBS. Clinical surgery said that it is only working after 6 weeks. Some of the drugs are still going on. Aripiprazole 30 milligram. She is using sertraline without tetrabenazine. I would like to inform you about the Voluntary Association of Turkish Tic and Tourette Syndrome patients. She wanted me to share her picture to inform you. It is possible to follow them through the social media and support them. Thanks very much.